I'm Dr. Debbie Cohen from the University of Pennsylvania. I'm a nephrologist and professor of medicine in the Department of Medicine. I have been a moderator at the Hypertension Scientific Sessions for 2020, and the session that I've moderated is Difficult Situations in Hypertension Management. I have two of the speakers here today, Dr. Hall from the University of Mississippi and Dr. from UNC, and they are going to just give us a brief overview of what they spoke about and give us some take-home points. So Dr. Hall, do you want to go ahead?
Thank you. I'm Michael Hall. I'm a cardiologist from the University of Mississippi Medical Center. I spoke about severe obesity as a cause of difficult to control hypertension. The reason we chose to speak about this topic is because it's not only a prevalent problem throughout the United States, but an increasing problem throughout the world and a major cause of hypertension, specifically difficult to control hypertension. We know that obesity is responsible for a number of mechanisms to cause hypertension, including activation of things like the sympathetic nervous system and renin-angiotensin-aldosterone systems. We also know that treatment of hypertension or treatment of obesity leads to reductions in blood pressure. And so I spoke about not only the mechanisms by which severe obesity leads to hypertension, we talked about numerous ways to lower blood pressure in severely obese individuals. Some of the topics I spoke about included diet. We referenced several diets that are popular, including the Mediterranean diet, DASH diet, and also intermittent fasting. Another way we recommend weight loss is by exercise, and I spoke about a number of specifically types of exercise therapies that we recommend. The problem with both diet and exercise is that despite these being good things to recommend, they can be effective to lower blood pressure. We know that they're very challenging to do over the long term. And in fact, most studies looking at combinations of diet and exercise have shown that most people with obesity end up regaining most, if not all, of the weight back within a short period of time. So there are other options for weight loss, specifically as it relates to the management of blood pressure, and those include weight loss medications. So I discussed both the medications are recommended for short and long-term weight loss management. Some of the problems with the short-term weight loss, these are 12 weeks recommended therapies, is that they have amphetamine-like properties, and therefore most physicians don't prescribe them frequently. There are other medicines that are out in the market that are FDA approved for weight loss, but they tend to have marginal effects on blood pressure, at least over long periods of time. And so I concluded my talk about speaking about bariatric or metabolic surgery as a treatment of severe obesity and the effects of metabolic surgeries on blood pressure specifically. We have many studies, observational studies, showing that weight loss surgeries, bariatric surgeries, are associated with significant weight reduction, also associated with comorbid conditions, remission of comorbid conditions such as diabetes, but notably have profound effects on blood pressure almost immediately after surgery. And there's emerging data coming out showing significant reductions in blood pressure in severely obese individuals. And most notably, a recent randomized controlled trial, the Gateway study, looking at a randomized study looking at patients who underwent Roux-en-Y gastric bypass surgery versus medical therapy, with the primary outcomes focused on hypertension control or remission. This study did show at 1 and now 3 years that Roux-en-Y gastric bypass is an effective way to lower blood pressure in severely obese individuals. And so my talk really focused on severe obesity as a cause of resistant hypertension, and then we discussed the multiple mechanisms by which obesity causes hypertension, and finally, different treatment options for patients with severe obesity who also have hypertension.
Dr. Voora gave a talk on refractory hypertension, and would you like to go ahead and just give us a summary?
Thanks, Debbie. My name is Raven Voora. I'm a nephrologist from the University of North Carolina in Chapel Hill. I spoke about refractory hypertension. So refractory hypertension, describes those patients, whose blood pressures remain elevated despite adherence to at least 5 antihypertensive agents, including a long-acting thiazide-like diuretic and a mineralocorticoid receptor antagonist. And while the prevalence of refractory hypertension does not appear to be high, managing these patients can be quite vexing. And so in my talk, one of the more interesting aspects of refractory hypertension that I discussed was, do patients with refractory hypertension, do they have a distinct condition from patients with resistant hypertension, or do they really represent extreme cases of resistant hypertension? And I think this is really an important question clinically, because if patients with refractory hypertension have a distinct condition distinct from resistant hypertension, then patients with refractory hypertension may benefit from special diagnostic and therapeutic considerations. So what I really tried to do in my talk was, compare refractory and resistant hypertension. And one of the main interesting aspects that I found is that it appears that resistant and refractory hypertension, they appear to be different in their pathogenesis. The group from the University of Alabama has done just a tremendous amount of work in this area of trying to figure out what is the pathogenesis of the failure of antihypertensive treatment in refractory hypertension. And in a number of their studies, they have demonstrated that refractory hypertension is characterized by heightened sympathetic activity. And so, which brings us to the other important clinical question is, how do you manage these patients? And so if refractory hypertension is truly neurogenic in origin, as these studies suggest, then it suggests that really we need effective sympatholytic therapies to manage patients with refractory hypertension, whether it's pharmacologic or device-based. And unfortunately, we just don't have data in this cohort of patients to demonstrate how to best manage these patients. But if other studies corroborate these initial findings that the pathogenesis of refractory hypertension is truly due to activation of the sympathetic nervous system, this really means that we really should be focusing a lot of efforts in this area. But at this time, we don't have data. Another area that we don't have data for with refractory hypertension is outcomes. It makes intuitive sense that these patients with refractory hypertension would have worse outcomes than patients with resistant hypertension, right? Because they have, very severe hypertension. And it's been demonstrated that patients with refractory hypertension have a higher prevalence of adverse comorbidities like chronic kidney disease and diabetes, and they also have a very high prevalence of cardiovascular disease, but no one's ever looked at the outcomes of these patients in longitudinal studies. So I think the takeaways really from my talk are that, refractory hypertension is defined different than resistant hypertension. It appears that these are distinct conditions based on the pathogenesis. And at this time, we really don't have any great data regarding how to best manage these patients, and certainly no data regarding outcomes.
So I had some questions for you guys. So Dr. Hall, I was wondering, with this severe epidemic of obesity and obviously how it affects hypertension plays such a vital role, do you think we should be referring patients for bariatric surgery sooner?
Yes, thanks for the question. I am a believer that we probably should be more aggressive with referrals for bariatric surgery in appropriate patients. We all know, as I mentioned, that the old methods that are, while good, are difficult to maintain. That's diet and exercise and other behavioral therapies. I do think it's important to treat obesity before the target organ damage is too progressed, specifically heart and kidney and vascular injury. we tend to treat these diseases or be more aggressive with those therapies after they already have established disease. So I do think it's important to evaluate prevention of target organ injury in severely obese patients. And I think bariatric surgery is a way to do that effectively.
That's great. Thank you. And Dr. Voora, I just wanted to ask you, with your emphasis on the sympathetic hyperactivation in refractory hypertension, do you think that there will be a major role for renal denervation, as you know, it's looking like it's becoming more to the forefront to come into clinical practice? I mean, do you think these are the patients that should be referred?
Yeah, as you mentioned, you know, if truly refractory hypertension is neurogenic and origin, then I think that procedures like renal denervation may have an important role in treating these patients. Now, I will tell you that specific testing of the safety and effectiveness of renal sympathetic denervation in this specific cohort of patients with refractory hypertension has not yet been published. But personally, if I have patients with refractory hypertension who I just cannot get them under control after 5-6 medications, I personally would pursue that as an option based on available data that we continue to accumulate. I think it makes sense to offer that to these kind of patients.
Okay, thank you. This was really interesting. This was a very interesting session on difficult to manage clinical patients with resistant or more difficult refractory hypertension. So thank you very much.